So I want to welcome you to today's discussion. My name is Brittany Hagedorn. I lead our U.S. healthcare efforts. And I want to welcome you to this discussion about testing population health models of care. And specifically, we're going to hear today from Claire Cordeaux. I'm very excited to hear what she has to say about her experience working internationally on how to look at population health and working with her experience working with hospitals and healthcare delivery networks of all sizes around how to think about their attributed populations, how to serve them, and how to manage the financial side of it as well. We want to go through a couple of pieces. First, understanding what is the demand for services from my attributed population. Then she'll talk about how patient care can be thought of as a process and how patients move through that process and how you would simulate and understand your system as a whole. And then look at how we test different models of care and their impact on utilization and cost and clinical outcomes, financial, operational, and clinical components of care, and how you build a business case for making changes to the standard care delivery model. So I'm really excited to share all of that with you, and I want to go ahead and introduce her to you. You're going to see here in just a moment her image, Claire there. She is our Executive Director for Healthcare at SIMUL8, and really she's going to speak on this. She is the expert on using Scenario Generator, which is our tool, to look at population health. She was one of the original developers and spent a long time working for the United Kingdom NHS, the National Health System, in doing strategic planning and really got involved in this from the user side of it. And then you can see me there as well, Brittany Hagedorn. So with that, I'm going to ask some questions of Claire as she goes, but she's really going to lead us through this discussion and share her insights. Claire, do you want to take it away?
Thank you very much, Brittany, and it's great to talk to everybody today. I was just reflecting as I was developing these slides and thinking about what I was going to say, that it's probably about 10 years that I've been working looking at population and planning for population health in all kinds of different areas, including working with social services, looking at workforce development, and in strategic planning in healthcare. And I use simulation to do this. I came to that really as in my experience of working within the National Health Service, as Brittany explained, because it seemed to me we needed something to help us think through some of the complexities of what it means when you're looking both at your population and the way in which they might access services. So what I want to talk to you today about is some of the work that we've done at that strategic level, planning for healthcare delivery networks, doing that planning with an understanding of the population that you're responsible for, looking at the flow through the network, and also testing new models of care. So understanding the impact on costs, on your capacity, on the volume of activity, and how that all forms the business case, how you can create the evidence that you need to be able to work out the best plan of action. And it's not, people use simulation in very complex ways for quite operational questions. But actually, when you're looking at the strategic picture, particularly if you're familiar with some parts of it but not others, simulation is something that can really, really help. So I want to share some of my experience as we go through this webinar. So first of all, I just wanted to clarify my understanding of population health for this particular purpose. I've spent some time in working in public health, and I'm really taking the population health definition rather than necessarily the sort of determinants of health definition from public health. So I've found the source that I've listed below very helpful. This was a survey of a number of people and their perceptions of population health, and it's very much this the idea that you're responsible for a particular population and its health and what the cost of care is likely to be. And that can helicopter in, if you like, to the idea of risk stratification and targeting specific patients that behave in particular ways and have particular needs. But it can also be about the total population, and I'll come on to what I mean a bit more about that. But for me, when you're planning services for a population, you're thinking about who is in my attributed population or my responsible population, what are their likely needs, and how can we understand what those are based on demographics and the disease prevalence, the diseases they're likely to have. And what's that going to mean as people access the service, as they move through the different points of service? What's the cost likely to be? What's the capacity likely to be? So that's how I'm thinking about planning services for a population. And the tool that we're using has this view of a whole system where, as you can see from the chart at the bottom, you're looking at understanding your population, understanding how they might come into the care system and flow through the different service points, and then the impact on your capacity utilization and the cost. So what you're looking to do is to understand the current state, and particularly if you're looking at a whole healthcare delivery network right from the first point of contact with primary care, for example, through to the hospital services and being discharged back out to the community. That's important to establish, and there's usually a huge amount of learning that we do at that point about how the system actually works, which also helps you to develop your what-ifs, your what if we do this differently, and understand how different organisations might interact better together. And then to look at how best practice would be implemented and test out those ideas that people have about how the system would work better, or indeed look at the clinical evidence for best practice and what the likely impact would be of implementing that. And then quantify those in terms of both financial impacts and also clinical impact. So what's going to happen to my system financially and to individual providers financially? What's the utilization, but also what are the impacts on my patients? How satisfied are they going to be? How much less sick are they going to be? Is this going to give them an improved outcome versus the previous treatment? Does this mean they're going to use more of my resources, or maybe wait less for their service? All of those sorts of things you can start to ask and test them out within a model. So I'm going to talk a little bit more now about understanding the population. So we tend to characterize a population as looking at the size, the demographics, and the disease prevalence as a way of measuring the likely demand. And I'll explain a little bit about how we do this using a few examples. I'm going to return to some of these examples from time to time as we go through the webinar. So this is an example of a population. You can see its demographics there. One of the things we're looking at is how that population is likely to change over time. So when you look at the population projections, what does that mean for demand? And that's giving you some significant information about how demand is likely to increase over time. So services will need to be able to respond to that. But we also multiply that by age-banded disease prevalence. So of course you can see an increase in volume of a particular population, but actually the demand for specific parts of the service is going to change depending on their age-banded disease prevalence. So if you have a group in your population where you have large numbers of children being born, then you can obviously expect a demand at that end. If you've got an aging population, you're going to expect a demand with the sorts of diseases that people who are older present with. And that will require different sorts of capacities in different types of areas. So we look at age-banded disease prevalence as a way of measuring demand. What we're doing here is looking at individuals within the population, but we're looking at the likelihood of those individuals needing services. So Mrs. Smith might have diabetes, but in the same year she might also have a mental health problem. She might break her leg if she's very unlucky, and all of these things will mean that she presents somewhere within the health system. And what we're interested in is the activity that Mrs. Smith produces, which the health system will need to handle. Now, you can obviously model at a far more granular level, where you're looking very much at an individual and how they move through the system, having multiple interactions because of the set of diseases they have, and we'll have a look at that a bit later. But at this level, we're looking at the activity that's likely to be need to be managed as a result of the population and the diseases that they have. So in this particular example, this is an example from Canada, we're looking at the demographic effects in order to look at the demand for maternity care. So here we've taken the population, we've taken the conception rates by female age band, so the fertility rates are published. We're looking, and that gives us annual births once we've factored in terminations, miscarriages, so that you end up with a number of annual births. Now, in this particular case, this particular system was looking at how you could understand maternity care demand by the insured and uninsured, because they use services differently. And so what they were wanting to do is to look at the growth overall of likely demand for maternity, but also to understand what the impact would be for particular providers and also for those who are insured and who are uninsured. This is that slightly more granular model that I was talking about earlier, which this one is very particularly looking at individual patients. So it's a state transition model, and it's looking at how patients individually progress when they have multiple chronic conditions. So as we know from the research, the older you get, the more chronic conditions you're likely to have. And in fact, the more recent research is showing that most people, it's much more common to have multiple chronic conditions than it is to have only one. And therefore, it's sensible to plan for the person with multiple conditions rather than just by their individual disease. So taking that as our starting point, we were looking at the way in which patients might transition from perhaps having one or two chronic conditions to having 3 or 4, to having 5 or 6, or to becoming in that very high group. And of course, they will need to access certain services depending on the severity and the number of conditions. And there's been some work we've been involved with in the UK, which has been very specifically looking at that transition rate, and also looking at all of the services that people access when they're in a particular state, as you can see in this model, and what the costs might be and what the volumes might be, and how you might be able to change that by proactively managing those individual patients. But it's the same it's the same concept. It's thinking about the population, thinking about the conditions that they have, and how that then determines the services that they're likely to access. And by looking at some of the secondary sources data, data published in journals, very often you can look at those sorts of progression rates without necessarily needing to delve deeply into your own data. And it's a way of associating some of the academic research really in this area with the actual data from practice and the activity that's going on, in order to predict what might happen in the future, and therefore the impact of particular new models of care that you're wanting to put in place. So I hope that gives you a bit of an insight into the way in which we understand the population and the demand that they're likely to produce. I now want to move on to outline how we look at the flow through a care model. So we've got the demand, it's now being pushed through a system of care which represents the health delivery network. So one of the things we want to look at is how does the population interact with health services. So we tend to model this from the first point of contact. Obviously, if you're looking at your whole population, you've got quite a high number of potential activity that might come into your service model. Now, a number of people won't contact the health service. They'll manage their condition on their own, and they might turn up later sicker. But what we're interested in is what's the first point of contact for a patient. So that might be their primary care physician, or it might be the emergency department, for example. So where do they go first? And then what's the likely progression from that first point of contact through all of the services in a particular, for a particular care bundle or disease progression, whether it's an emergency or a scheduled type of event. And of course, most activity is managed in a primary care area. That's where the highest volume, but the highest cost activity is handled within the hospital area. And so it is fewer people that transition there, but they transition very often as a referral from elsewhere. So most of the interventions that you're going to want to test out are actually going to be prior to the hospital, particularly if you're looking at managing people with chronic conditions. So it's important that we understand how they're currently accessing services before they get to a hospital. So that's one of the, yeah.
If I could just jump in and kind of reiterate something you just said, I think what's really important, and the point you're making with this from the first point of contact, is looking at your system and saying, what are the questions I'm trying to answer, right? And if I'm interested in what's the impact of access to primary care, or what is the impact of changing the way people access urgent care or emergency services, that's where I define my first point of contact. And then I just run the patient through whatever process that they would normally go through until their issue or their disease or whatever is resolved. Is that a correct statement?
That's right. But one of the other things that you need to take into account is, of course, you might have a group of patients who have a particular set of conditions, and you validate that with the numbers that you see in your service, so you know you've got your current state right. But of course, depending on your population, people behave in different ways. So we all know that patient behaviours are influenced by their lifestyle. I was talking to a health delivery network the other day who were saying that whilst they were seeing increased numbers of older people in their emergency department, actually it wasn't a huge increase, and the issue was that they were more complex, so they tended to stay longer and were more likely to be admitted to the hospital. Actually, the huge increase in volume in their emergency department was the 0 to 30s, which is probably about lifestyle, about access to care. So there are all sorts of ways in which patients behave differently. There's also the distance to the service. We know more people are likely to go to the emergency department if they live closer. Depending on who's paying for the service will dictate how they will use it, as well as their health needs. So quite often you see a population where the health needs are really quite considerable when you look at them from a population health perspective, but actually you don't necessarily see a huge number in the emergency department because they wait until they're really sick to come, but you do then see a much higher likelihood of being admitted, for example. So all of these things play a part in helping you understand how people move through services. Sometimes you'll come across a system and they don't have that, they have relatively few compared to the national benchmark emergency department attendance, and you wonder why that is, and you discover that actually their primary care is really proactive, and so a lot of people are being managed at home. And you see these differences when you're validating a model which is looking at a whole system flow. Does that cover your question, Brittany?
Yeah, I think the point you're making is that it's important that we look at the entire system, right? And if I want to think about managing my emergency room and admissions and readmissions and how that whole system works together, I need to think about the separate populations, and that's why kind of generating the demand from a population and then running it through the system is so important. I mean,
Yeah.
really, if I have that correct, yeah.
Yeah, no, absolutely.
Right. Cool, thank you.
So this is an example of a dementia care model. So this combines that that transition model we saw earlier with people with multiple chronic conditions. And so you can see people moving from a mild state to a moderate state to a severe state. And of course, people develop dementia over a period of time. People who have mild dementia are not always diagnosed, so they won't necessarily be receiving services. But as they get more severe, then it's generally picked up, and they probably will be receiving services. And that whole process can take a number of years to move forward. So it's probably 8 to 15 years by the time you become severe if you've been picked up at the mild stage. And of course what we're trying to do is keep people as independent as possible in that mild to moderate stage so that they don't get to that severe stage. But you need different services at different points. So depending on when your first point of contact is in the system with suspected dementia, then you won't get your memory assessment services until that point. So that depends on whether people are diagnosed, and it depends at what level of dementia. So you can see how that kind of progresses. So that's a model that sort of explains how we're looking both at flow, but also looking at the services that people might need linked to their health need as well as their use of service. Hepatitis C is another example of this. So we're looking at progression of disease here. And on the left-hand side, you've got the diagram from the published research on disease progression, and you can see how that's then been turned into a simulation model. Now, the purpose of this particular model was to look at the impact of treating people with hepatitis C. We found in the UK that actually only about 2% of people with hepatitis C were diagnosed. If they're not diagnosed, then they keep moving through this disease progression, and they will access different services on that way as they become sicker and sicker, and of course those will have increased costs. But if they are diagnosed, they will start to receive treatment, which means that they have less likelihood of progressing, because they then don't move through that disease progression. And so what we're looking at here is the way that people in a population are experiencing their disease, whether or not they're in contact with a health service, and then what impact there would be on a health service of trying to identify more people with hepatitis C on the likely utilisation of services at a later stage, and then the trade-off with the cost of that intervention. So again, taking your population, flowing it through the services that people are likely to need. So it's quite a high-level progression. Going back to that maternity pathway that we looked at when we looked at the simulation, the population simulation, we had two pathways here. This is the standard maternity, the start of the standard maternity pathway where people move through, and where they're receiving. I mean, there'll be a proportion with who are high risk, but actually those will be relatively low, and people will be receiving regular appointments as part of their antenatal care. And the site that we worked with in Canada was looking at the complications for uninsured people who tended to come in much later in the pathway. They didn't access antenatal care services, and then they had multiple admissions. They might even have had an inpatient stay right from the point that they were identified to the system until delivery. So very different experiences of that pathway of care depending on who you were. And of course the question was, well, if we dealt with this group differently and they did receive antenatal care, what would the impact be on the system? What would the impact be on our costs overall? So you're mapping out the flow of events depending on your patient types as well as the condition that they have, which has obviously got a clinical progression to it, and how people are likely to access service in order to understand what the likely demand might be. So we've covered how we understand the population. We've covered some examples about how that population flows through care models. I want to come on now to testing new models of care in this particular area. So the first one we're going to look at is that example of maternity complications. And in this particular case, there was Toronto had a population of uninsured maternity patients, and people were concerned about their proper prenatal care and therefore their complications, so that when they come to the health service, it's a much higher cost because they have those complications at a very late stage. So the question was, what could you do about that if you provided antenatal care? And so a number of questions were asked about utilisation of beds, how long people stayed in beds, and what the likely impact would be. So you can see here the results where we're looking at the likely length of stay for C-section versus vaginal birth. And in fact, one of the other questions that the system wanted to test was what would happen if more people had vaginal birth as opposed to C-section. And of course, you can't allow any delay, so you really have to have enough beds. We've got more than enough here in these particular results. You have to have enough beds to make sure that when somebody needs a bed, they can have it immediately. And one of the big questions for providers is, well, how many beds is that then, and how many do I have to have? Will I expect to have empty to make sure that when I've got my my peak demand, I've got enough? And that's a very common question, of course, when you're looking at planning for healthcare, and one which simulation is very helpful at solving. So one of the questions was, well, what happens if we if everybody was insured? What difference would it make? And it makes a small difference to the utilisation of beds, and you can see the impact on cost. And also, similar question, if there were 5% fewer elective cesarean sections, again, reduction in utilisation, small reduction in cost. So if you're looking at making the best of your bed stock, and also looking at how you might deal with demand, and also trying to look at the patients that might be coming through with additional complications. These are the sorts of things that are all key variables in how you manage your maternity care pathway. And what this particular system did was ask a number of what-if questions to try and understand the impact on their resources. So another example I wanted to look at was of increasing access to primary care and reducing unscheduled admissions. And I'm sorry, that was, actually, I'm not going to look at that, I'm going to look at that in a minute. I'm looking at the Toronto Food Bank here. Again, this is another example. This is with Mount Sinai. And one of the questions here was to look at the reduction of emergency department visits with people who are coming to the food bank. So the question was, if people are not attached to a primary healthcare provider, then they might be much more likely to go to the emergency department for their healthcare. And what would the impact be if you brought in a nurse into the Toronto Food Bank and they routinely saw patients and supported them and provided access into services, so into primary care, mental health, and some of them, of course, would need to go to the emergency department because they needed to go there. But if a nurse was able to provide that primary care, what would be the impact? So looking at the baseline, we could see that the emergency department visits cost just over $1 million. And the hypothesis was that if you had more nurses, then you would be able to reduce those number of emergency department visits. But they wanted to have some evidence of that before starting to invest. So when we thought about what that nurse service might look like, we were thinking, well, how many appointments? And in fact, if you've gone to the food bank because you haven't got, you need to get food for your family, you've probably got lots of other responsibilities. You're not going to be hanging about waiting a long time for your appointment. So if they wait too long, they'll probably go home and they'll probably end up attending the ED. And then what's the cost of all of that? So we had the scenario where we were looking at a certain number of visits a year, we were looking at a nurse operating 48 hours a week, and you can see that we looked at the cost implications of a new appointment or a follow-up appointment against the visit to an emergency room. So here's our process flow here of looking at introducing a nurse, and you can see that we've now got fewer visits to the emergency department. We have got some people going into the emergency department here as a result of seeing the nurse because they needed to go, and we were able to reduce the cost, which is including the new cost of nursing and any ongoing referrals to mental health services and primary care, by about $300,000. So the business case then became much clearer that in fact it would be a beneficial thing to do, not just for the people coming to the food bank who were not seeing primary care providers, but also for the cost to the system.
Claire, can I just clarify on that? So,
sure.
My understanding of what you just said, you had a cost of over $1 million, right? Something like $1.1 million. And by adding a nurse 48 hours in the food bank, you were able to save 25% of that cost, $300,000, just by having a nurse who's able to catch people and diagnose them and get them the care they needed more promptly.
Yeah.
That's incredible. All right.
And it's an interesting point because, of course, you know, there is a difficulty of investing in healthcare. You know, it's a big question, do we invest more in healthcare at particular levels because actually it's going to save us money, but what's the issue regarding insurance? And that's something that is a struggle, I think, for any overview system to look at. But in this particular case, and in the case of Mount Sinai, they were able to then put that case, and I believe that they've now attracted foundation funding to look at putting in that service. So it was a win-win situation for everybody.
What was the timeline on that? Was that a first-year impact?
Yes. Yes, we modelled it just in 1 year.
Excellent.
So then the last example I wanted to look at is reducing emergency admissions by seniors. And this is, I'm grateful to the Kent Surrey and Sussex Academic Health Science Network for allowing me to share this. The question here was that as the population ages, there's a greater need for unscheduled care, or certainly a greater demand. And, you know, some of the questions that I think we're all asking ourselves is, you know, how can we reduce emergency visits and therefore the knock-on to emergency admissions and the readmission penalties. And one of the things that people are looking at is that, well, where are my most complex patients? How can I work with them more proactively? How can we make sure services are available, particularly if their needs can be dealt with outside of the emergency department? So the hypothesis here is if you have a primary care service 24/7 with the right people, with the right skills, then seniors' needs could be met in that environment. And the assumptions of that service was that if you were going to avoid an emergency room visit, you would need 3 primary care visits over 3 days with 10 to 60 minutes per visit. So it's quite high-level stuff, but this is what the recommendation was. And the kind of key staffing there, of course, they would be overseen by doctors, but experienced nurse and therapists would be the key people required to run the service. So a clinical review had looked at, you know, what the avoidance of emergency visits might be, and suggested that, well, let's look at what would happen if we rerouted 50% of ambulance calls, 50% of the calls to the emergency department visits that come from a care home, a residential care home, 50% of out-of-hours service, and 50% of primary care. So this is the what-if that they looked at. And this is the simulated pathway. So the cost of admissions in the baseline there was 23 million. And you can see the number of admissions at this stage here. So this has started from the first point of contact. It's gone through all the different services that people might go through in order to access the emergency department, as well as a number of people just walking in. And then you can see their admissions. And we can also see the bed occupancy there. So You can see the variation there over the period of time, so there's obviously peaks and troughs within that, and the average. So the question was, what would happen if we made a change? And obviously, as with any simulation, you validate that first. So we got our historical data in line with our simulation data until everybody was happy that we were looking at a reasonable picture of a model of a whole system. It was producing the right figures to recognize it as being pretty like the real thing and good enough certainly to answer these questions. So what we did was then set up a new part of our model, which is looking at this new locality hub, and as a result of that we could see the likely reduction in admissions, therefore likely reduction in savings, and the change in bed occupancy. Now obviously the fact of setting up a primary care locality hub and talking to all of the different organisations that might refer into that hub and looking at the likely progression through services in the hospital is going to take a considerable amount of time to implement and discuss with the system. But one of the reasons that they wanted to use this was to really get a quick idea of whether is this a good idea, how much is it, how much is it going to save, what's the likely impact on the system, is it worth going further with this idea in order to start engaging my stakeholders. And one of the questions they wanted to think about was, well, how many staff would I need if my kind of key staff are going to be these experienced nurses and therapists? How many of those am I going to need for a 24/7 service? And they worked out that, well, they were able to model that that with that sort of demand, they would need 5 full-time equivalents on call 24/7, which is probably about 15 members of staff in the first year. And you can see they're 85% utilised. So that's probably quite a high utilisation rate for when you consider this is face-to-face time, the time spent with the patient. But nevertheless, that would probably be reasonable. They then modelled this forward using their population projections and that disease prevalence calculation, look at the age band disease prevalence, to see what the demand would be between the existing and new models of care. And you can see here the difference between the sort of existing emergency attendance and the new model of care attendance. So of course it's going up, and there are slight peaks and troughs in the population and how that's likely to change the likely demand. But you can see the impact on emergency department visits and also emergency admissions over time. And a further question then was, well, okay, if we have those 5 members of staff in year 1, how long is it going to be? Are we going to be able to cope over the next 5 years? And you can see there from the graph that the service starts to fall over really by about year 3. And so we tested it in the model with hiring further equivalent of 3 staff to bring the service levels back with the target. So people, obviously, again, you wanting to make sure that nobody ever waited, otherwise they'd just go to the emergency department anyway. So those staff had to be available at the time that they were needed. So that answered the big question by looking at the population, looking at the flow through the whole system, looking at the likely impact of the change. So I just want to come on to some conclusions now about that, and I'm just going to hand over to you here, Brittany.
Yeah, Claire, thank you for all of that information. Whirlwind of tour of a couple of really interesting case studies. So I guess what I want to do is take a moment and reflect on what you've just said, and I think really the important part for us looking at the change in care models and rethinking where we allocate capacity in our healthcare delivery networks, the balance of inpatient versus outpatient and things of that sort. And really a lot of that is being driven by the fact that a lot of providers, a lot of networks are starting to take on that increased financial risk. So as we move towards different kind of payment structures, as the health delivery network, I now take on some of that risk for whether or not you use the emergency room, or you need surgery, or you see your primary care and resolve it that way, whether or not you allow it to progress, all of those sorts of things. And what I thought was really interesting, but a couple of these examples, is that there's an immediate payoff for investing in new care models, and there's an immediate payoff in both financially, right, reduce costs, which is, of course, very important, but also clinically, right? If I can get you the care that you need sooner, faster, in a safer, easier to access environment, there's all sorts of downstream effects for that. All sorts of things we haven't even talked about, like preventing you from getting an infection because you spent a couple of days in the inpatient unit and picked up something. As long as you were there, prevention of falls and adverse drug events and all of these other preventable harms that are also equally important. And so all of those downstream clinical effects are in line with the financial incentives. And I think that is kind of a new environment that we're starting to move into, and actually really exciting to see some of the immediate payoffs that you've been pointing out here. I also think it's interesting that you've been talking about the attributed population, and how do we understand that population, how it's going to change over time. Even a couple of years can really change what that population needs from in terms of services. And so being able to look at that and project that demand, and then understand how it's going to impact my utilization, and if my utilization gets too high, when do I need to add staff, and being able to plan for some of those things 2-3 years out is really powerful. I think the key from the simulation perspective, obviously, is that chance to evaluate those changes and those investments in that risk-free environment. Let's test it out, experiment, maybe play with some crazy ideas that we think might work, but we couldn't necessarily go hire 10 people and just try it out in the real world. We need an environment where we can kind of get a feel for whether or not it's going to be effective. And that's going to allow us to do more step change initiatives as opposed to kind of incremental pieces, right? We know that coordination of care is important. Incrementally, we're going to do that. It's going to have a good return for us. But something like the locality hub, that's a fundamentally new approach to care. And there's not really a good way to test that or to pilot that without a tool like this. So I think that's a really important piece. And being able to look at across all of those different impacts, right? The financial, the clinical, and the operational. So I'm really excited to hear our audience's perspective on it today, because I think this is kind of a fundamental rework of the way we think about changing our systems and really thinking as a system. So thank you for sharing all that. I'm really excited to hear the conversation further and see what questions have come in. So momentary reminder, please submit your questions on that chat window on the side. We'd love to have Claire answer some of those for you today.
Thanks, Brittany. So I've talked about how we've been doing some of this work and how we've been helping other systems to do it. And I just wanted to mention the software that we've been using to do this. You heard me mention Scenario Generator a couple of times, I think, during that presentation. Scenario Generator is something that came out of the UK National Health Service, and I was very involved in that process of developing it. And it's very deliberately for strategic planning for healthcare delivery networks. In the UK, we have a system which is based on a population planning view of the world, and finance is allocated on that basis. And so you're planning for the health needs of your population. But it's been very interesting to us how it's been adopted in Europe, in Canada, the Australian government. We've just been in Qatar training people to use it. So this concept of having a population that you're somehow responsible for, that is likely to use your service, and understanding how they're going to use those services is clearly has global relevance. And the idea is that you do use it at that strategic planning level, and you quickly answer those system-wide questions. So that's an important thing, because I think we have so much data now. The electronic care record can tell you a huge amount, but it still takes quite a long time to decide the questions you want to ask and then look for the data and start to answer them. And in fact, at this system-wide level, you really need something that's going to very quickly help you make sure that you're going in the right direction, to focus on the areas where you really need to concentrate. And so we built Scenario Generator with some pre-built pathways of care which represent the general trend of how people tend to use services. And they can all be changed by the user, but the idea is it's quick to get into, so you haven't got to start to build your whole system from scratch. And there's data already in there, so you can just select your population and immediately start to test your scenarios. So anybody who uses simulation knows that it's as good for getting you thinking about your problem as it is for getting you results to your problem. And so anything that means you can cut down on the modelling time and the thinking time, or the modelling time, helps you to get into the complexity of the question rather than worrying about which buttons to press. So that was always the intention with Scenario Generator. Also, the benefits are that because it's using some of the published data as opposed to, and you don't have to trawl through all of that yourself. And as Brittany said, we're moving into new territory here. So where you haven't got historic data for a whole flow of patients, it's useful to start to use this in order to try and work out what the impact is going to be. Now, I mentioned that it's quick. I mean, that last project I talked about, which is about implementing a primary care locality hub, we did in 4 days. So we think that that's really worth it, because it gives you so much insight, and it may be that you go on to build a much more complex model to look at actually how your primary care locality hub will function. But at least you've got a good data for a business case that this is a great idea, that it's likely to work. We can test. We've got some measures to help us test how successful it's being against our evaluation. So one thing we wanted just to end with is we've got a challenge for you, and a challenge for us actually, is that we want to encourage ACOs to use this tool. We think that other population health systems who've been using population health have found it helpful, and it will be helpful to ACOs. So we're happy to provide you with some results for a new model of care. If you give us your model of care and your data, we'll give you the results using the 4 days. And we'd like people to apply to us to do that if you're interested in knowing a bit more. So we'd love to work with one of you to do that. So that's really what I wanted to say. Please, I'm just going to pause now for any questions that you might have about what we've done, about population health in general, any comments you want to make about how you're planning with population health in mind.
So Claire, there's one question here. So you've talked a little bit about the data. Not all ACOs are really sure who's in their population, particularly if they're just getting started. They might know kind of at a high level, how big their population is that's been attributed to them. So let's say I've got 50,000 patients attributed to me. What else do I need to know in order to be able to start doing some planning and using Scenario Generator in that context where my historical data may be a little shaky, or I may not have access to it because I'm a new ACO and just trying to get all my systems to work together? Can you tell us a little bit about what's kind of that minimum viable data set?
Right, okay. So 50,000 patients, that's a good start. But what I'd also like to know is what are the age bands of that population? and it doesn't have to be every single age group, but it can be sort of 5-year age bands. The data that we use for looking at disease prevalence has actually come from the UK NHS. It's a sample of 100 primary care practices, and it looks at the whole of the ICD-10 range. And we've used it because it's a consistent source for all disease types, so you're not kind of counting apples and pears when you're doing it. But actually, when we were putting this tool together, we also looked at other sources, like looking at all the sources listed in wrongdiagnosis.com and various other places. And the thing is, it is useful to use that consistent approach. And when we've used it with other countries, we've not been far wrong. And where we've known, because there have been individual studies in those populations that, cases of skin cancer are higher or whatever, then we've just uploaded and increased the prevalence for those particular dates. But I would say, when you're first getting started, if you've got your age-banded population split by gender, use that disease prevalence as a first start, and then what you need to have is probably your emergency department attendance, your emergency admissions, your outpatient attendance if you're looking at scheduled care, new and follow-ups, and your scheduled inpatients. And starting with that, actually you can get a huge amount of insight as to how your system might be working, and depending on the question that you want to answer in your simulation, you can then work out which piece of that simulation you need to delve more deeply into. Does that answer the question?
I would guess so. So if I hear you correctly, so if I have my population, my age-banded and gender segmented demographics, and if I'm interested in emergency care, then I need to know roughly how many admissions I have, how many visits I have, kind of the general sense of what's happening in that system today, so that I can validate before I experiment. Is that correct?
That's correct.
Okay, excellent. So that is the only question that we've had so far. The other, well, there's one other, and that's just more of an operational question. So we have a question from Randy. Great presentation. Can we get a copy? So yes, of course, that will be available. The webinar recording and also the slides separately will be available at simulate-healthcare.com tomorrow. And you will also receive an email with the link to that recording tomorrow when that is published as a thanks for attending today. So you can share that, revisit it, let us know if you have any questions. We will also be hosting questions on the LinkedIn forum, simulate-healthcare.com. No, that's not where the LinkedIn forum is. Obviously, it's on LinkedIn.
Simulate in Health.
Simulate in Health, thank you. So if you have any further questions, we can answer those there.
If you're not a member, just click on it, and we'll approve you happily.
Great.
So if there's no further questions, I just wanted to, as Brittany said, invite you to continue the discussion with us, as she said, and do email us individually as well. And if you're interested in coming to our next of these webinar sessions, and the next one's going to be in July, we'll send you details of it, and it's going to be looking specifically at simulating bed capacity.
Great.
I just want to end by thanking everybody for your time. Really great to talk to you today, and hope to talk to you in the future.